Welcome to This Explainer. Today, we're taking a deep dive into something that touches, well, almost all of our lives in one way or another: chronic pain. If you've ever dealt with it yourself or cared for someone who has, you know firsthand just how incredibly complex it can be. But, as we're going to discover, modern medicine is fundamentally shifting the way we understand and treat it. We're finally moving away from those old assumptions and embracing a much more holistic, effective approach. To put this into perspective, just look at the sheer scale of the issue. Get this, nearly 1 in 5 Americans report having chronic pain. Just let that sink in for a second. That's a massive portion of the population. This isn't just some niche medical issue, it's a widespread epidemic. In fact, it's one of the absolute most common reasons patients seek healthcare in the US today. And it's a seriously complex puzzle that primary care practitioners have to navigate every single day. So here's our roadmap for today. We'll start with the chronic pain epidemic, then unpack the pain experience, discuss setting the right goals, navigate the medication maze, and finally, we'll look beyond the prescription pad. All right, part 1, the chronic pain epidemic and meeting Mrs. Smith. Let's introduce the human element behind all these statistics. This is our patient, Ms. Smith. She's 59 years old, and her medical history is pretty complicated. She was in a motor vehicle accident 2 years ago and also has degenerative disc disease. But what's truly crucial for us to grasp here is the impact. Her daily walks? Totally stopped. Her social life? Basically reduced to those brief moments when her daughter drops off meals. And honestly, the most devastating part is that she's entirely unable to care for her 1-year-old grandchild because of the pain. This perfectly validates the severe, isolating frustration of chronic conditions. It's not just about the physical body, it's about a life that's been put on pause. Moving right along to section 2, unpacking the pain experience, specifically diagnosis and assessment. Okay, so this point is absolutely crucial. We really need to understand the difference between nociception and pain. Think of nociception as your body's hardware at work. It's simply the nervous system processing raw physical stimuli, like tissue damage, extreme heat, or pressure. But pain? Pain is the software. It's the holistic, physical, psychological, and social experience of that initial signal. You can actually have nociception without feeling pain at all, and conversely, you can feel severe pain long after the initial nociceptive trigger has healed up. So, how do doctors figure all this out? Well, they have to play detective, usually using the old CARTS assessment. They systematically check the onset, location, duration, the character of the pain, what aggravating or relieving factors exist, the timing, and, of course, the severity. But because chronic pain is so holistic, doctors also rely on tools like the PEG scale. That stands for pain, enjoyment, and general activity. This makes sure the doctor isn't just, tracking a random number from 1 to 10, but rather measuring how the pain is actively interfering with the patient's actual day-to-day life and happiness. Connecting this right back to Ms. Smith, her doctors need to classify her specific types of pain to treat them properly. That chronic lower back aching she has from degenerative disc disease, that's nociceptive pain, which comes from non-neural tissues. But that sharp, tingling sensation that's been radiating down her right arm ever since her car accident, that is neuropathic pain, involving the sensory nervous system. And this matters because different types of pain require completely different medical tools. Now, this brings us to the very core of modern pain management, the biopsychosocial model. It's basically a 3-part puzzle. Treating Ms. Smith's physical tissue damage is only one piece of it. We equally have to address her worsened mood and depression, that's the psychological part, and her inability to see her family, which is the social part. Pain heavily affects mood, and a terrible mood just amplifies the pain. It's a vicious cycle that has to be treated comprehensively. Section 3. Setting the right goals, focusing on function over elimination. During her visit, Ms. Smith asked her doctor this really desperate, heartbreaking question. Will this medication take the awful pain away? I mean, it's what every single patient wants. But to genuinely help her, medicine has to pivot the narrative. We have to shift away from the unrealistic expectation of total pain elimination and move toward the reality of active pain management. And here's exactly why that mindset shift is necessary. Acute pain is an adaptive alarm system. You touch a hot stove, the alarm rings, you pull your hand away, and the alarm stops once the burn heals. Makes sense, right? But chronic pain, that's a faulty alarm system. Because of prolonged changes in the nervous system, the alarm just keeps ringing and ringing even when there's no active danger. So the ultimate medical goal isn't necessarily to completely erase the alarm, because that's often impossible, but to reduce its impact so the patient can actually get back to their daily function and reclaim their quality of life.
Section 4. The Medication Maze and Targeted Pharmacology. Since Ms. Smith has multiple pain generators, she's going to need multiple, highly targeted tools. Acetaminophen or NSAIDs are brought in for her nociceptive lower back pain. Then we look at SNRIs like duloxetine. What's absolutely brilliant here is that an SNRI targets her neuropathic pain while also providing independent benefits for her concurrent depression. Two birds, one stone. Finally, anti-epileptics like pregabalin are incredibly targeted for nerve pain and fibromyalgia. It's a carefully balanced cocktail aimed precisely at her needs, while keeping a really close eye on potential side effects.
Now, we definitely need to talk objectively about opioids for a second. The clinical data actually shows limited benefit for them when we're dealing with chronic pain. They are not considered first-line medications, mainly because they're rarely fully effective for this specific type of faulty alarm pain. Clinical guidance states they should generally only be considered after other therapies have been heavily trialed, and always through a lens of patient-centered, shared decision-making.
All right, Section 5, Beyond the Prescription Pad. Let's look at holistic interventions.
The most evidence-based strategy for chronic pain is an interdisciplinary approach. It is not just a pill. It's a full-on program. Step 1 is physical therapy and exercise to help address Ms. Smith's physical limitations and that cervical disc disease. Step 2 is cognitive behavioral therapy, or CBT. This is huge. CBT directly tackles pain catastrophizing, which is that awful psychological cycle where the intense fear of pain literally makes the pain worse. Only when combined with Step 3, targeted pharmacotherapy, do patients see the absolute best improvements in their daily function.
We also have to get real about how different substances fit into this journey. Mrs. Smith has recently started drinking about 8 to 9 alcoholic drinks a week just to cope. Objectively speaking, clinical data shows frequent alcohol use actually worsens chronic pain over time. And what about cannabis? Well, the medical data right now is pretty limited and constantly evolving. While there might be some synthetic products that show a bit of benefit, we also have to consider the real risks of cognitive impairment and cannabis use disorder. On the flip side, integrative medicines like acupuncture and yoga do show some positive, albeit limited effects, which makes them a really fantastic supplement to her core therapy.
And that brings us to a really crucial wrap-up. Chronic pain is often an invisible illness, but its devastating impacts on the physical, psychological, and social parts of a person's life are undeniably real. By shifting our primary goal away from impossible pain elimination and toward functional pain management, we can actually give people their lives back. So the question I want you to walk away with today is this: how can we better support and validate those in our own lives who are quietly living with these invisible chronic conditions? Thanks so much for joining me on this explainer, and as always, keep learning.